Коллеги, добрый день.
Good afternoon, dear colleagues. I will take 10, I'm happy to welcome you, and my objective is for 10 minutes to tell you about the role of the clinicist and our experience in using electronic medical records from the point of view of real-world data. If we have already determined the terms, the relevant terms, but as to how RWD will be turned into RWE is a big issue. For 3 years, we have been analyzing electronic medical records from the point of view of the data they contain and the trend that has been visible in the growth of publications on this theme shows that the role of these data is becoming more and more serious. If previously we mainly dealt in cardiology, but now we have projects connected with other fields, clinical fields, such as oncology, for example. Real-world data per se is a large layer of data, and for the 3 years that we have used them, they have grown in bulk 3 times, and they enable us to answer some of the questions. But approaches to them have not yet been finalized, and our goal in this presentation to show what approaches are used by us. As to the medical informational systems that have been mentioned already today, there are about dozens of them, but 5 or 6 informational systems are leaders. And they have different structures, different introduction and storage of the data, and has an effect on the processing of this data and on the evidence that we can get from these data. Important aspects that are to be taken into account that will affect the evidence received from electronic medical records are the follows. First of all, types of procedures that are contained in the medical record, from what organizations the data are received, and the parameters that are contained in these records. Parameters can be divided into the quality parameters, for example, availability of documents, the way they are filled in, types of documents, and quality parameters. And quality parameters are a cornerstone for confidence in this data and for their further transfer to evidences. This slide has been shown by Alexander Gusev already, but I have modernized it a little bit. And we see that the possibility of mistakes, the risk of mistakes is very high in medical records. And of course, that will depend very much on who introduced the information into the electronic medical record. And it is sad to admit, but the greater is the role of the person in introducing the data, the higher is the risk of the mistake. And by our data, the most reliable data are received from laboratory documents. The lower confidence, all the others are of lower confidence. especially the reports about patients' examinations that are written by doctors in accordance with the format. Well, let me give you some examples. You have a screen of the release document. So the main diagnosis is hypertonic disease, but another code is used in the statistical fields. For this or that reason, an error was made that has an effect on the analysis of this electronic medical card. Or another example, when the patient completed treatment, but data were introduced after the date of in accordance with the format. And I have a question whether the doctor introduced everything correctly into these examinations, and what is the role of the error received that can happen when the data are introduced in this way. We understand that the risks of errors in medical records can be observed on the entire journey of the patient, from the patient to the doctor introducing data into the electronic medical record, and their storage in the informational system.
При подходе к обработке данных электронных...
And when processing the data from medical records, we decided to take into account three basic points of the clinician's participation to manage these risks. And first of all, it includes the analysis of the correctness of methods to receive data from medical record, to retrieve data from medical data. The second is analysis of primary data. And before they are presented for processing. And the last stage, at the last stage, the clinicist comes to the stage, he looks at the results, analyzes them, and make conclusions about the conformity of this data with reality. And this is an example of the first approach. This is an audit of an NLP model, how it retrieves the data from the medical record. Here we analyze instruments with the help of which we get some parameters that are important for the further analysis. We understand very well that NLP models are far from being ideal, and providing new texts in the course of work, we can assess the success of this data retrieval or finding the error. The first example is the hypertrophy of the left ventricle was retrieved incorrectly from the medical record. That shows that we must pay more attention to the retrieval of the data. The second example is modeling outcomes in oncology, breast cancer. There is a boom of therapeutic approaches to patients in oncology because new markers have been found that make treatment more effective. And there are more and more target drugs that affect the outcome of the patient. And making the primary set for the analysis, it consisted of 64 parameters that were considered to be very important for forecasting. Each of these parameters had its own characteristics. We studied these characteristics in e-medical records, analyzed the average figures, maximal and minimal figures, the number of filled-in entries in the primary set of data. And the doctor made a conclusion that this data corresponded to real-world data or not. Also, they assessed the completeness of the entries. If there is a necessity, we can go even deeper into a specific case where is some conspicuous value or something else, and it is checked for the accordance of the task that we are fulfilling. And then this data went to the machine training. About 12,000 patients participated. And as a result, we included the data of survival in breast cancer. We calculated various metrics of accuracy, and by the result of this training, based on the result of this information, we made an examination of those cases that were sent for training. We analyzed the negative and positive cases, those that were in the cut-off point, and made a conclusion as to what extent this data coincided with the doctor's ideas. And this probably this approach is one of the steps to get valid data that could become evidence. And so the conclusions are here.